Hello everybody. Today we are going to discuss about COPD and asthma exacerbation. We'll start with definition. Asthma exacerbation are defined as episode of increased symptom and progressive decrease in the lung function that requires change in treatment. Increase in symptom like shortness of breath, cough, and wheezing. COPD exacerbation are episode of increased dyspnea, cough, and both, and sputum, often accompanied by tachypnea, tachycardia, or both, that worsen within the 2 weeks from symptom onset. About triggering factors, these heterogeneous events are caused by the complex interaction between trigger and the patient's immune response. Viruses are implicated in 40% to 50% of asthma and COPD exacerbation, and virus-induced COPD exacerbation are associated with increased healthcare use and prolonged course. Bacterial infection are thought to be more important trigger for COPD exacerbation. However, uncertainty remains around the role of bacteria in both diseases, particularly severe asthma exacerbation in which bacterial infection have been identified more frequently. Environmental and the food allergen can trigger asthma exacerbations, and air pollution and extreme heat is also responsible for inducing both asthma and COPD exacerbations. Now about initial evaluation. Asthma and COPD exacerbations are clinical diagnoses without disease-specific confirmatory lab and radiological findings. Thus, it is important to consider other diseases that can mimic and precipitate an exacerbation, including pneumonia, pulmonary embolism, pneumothorax, heart failure, myocardial infarction, as well as less common conditions like anaphylaxis, angioedema, and vocal cord dysfunction. Pulse oximetry is the primary method to assess oxygenation, and recognizing it may overestimate the blood oxygen content among patients with dark skin tone, but an ABG assessment should be considered in selected patients. Sputum bacterial culture and viral pathogen testing are indicated in both asthma and COPD exacerbation, although bacterial culture results should be interpreted with caution because colonization can occur in both severe asthma and COPD. Now about initial evaluation and severity assessment. Initial evaluation consists of pulse oximetry to assess SpO2 and heart rate, ABG, fatigue and somnolence concerning for hypercapnia, peak expiratory flow and FEV1 less than 50% of predicted or other clinical concern. Testing for respiratory viral pathogen and the sputum bacterial culture, initial chest radiograph, ECG and BNP, clinical assessment for pulmonary embolism, consider D-dimer and CTA on case-by-case basis. Now, defining severe exacerbation. In case of asthma, if respiratory rate is more than 30 breaths per minute, if heart rate is more than 120 beats per minute, if saturation is less than 90% on ambient air, peak expiratory flow of less than 50%, patients predicted or best. And then for COPD exacerbation, respiratory rate of more than or equal to 24 breath per minute, heart rate more than or equal to 95 breath per minute, SpO2 of less than 92% on ambient air, or both, or dyspnea visual analog score more than or equal to 5, CRP more than or equal to 10. Then assess severity. After confirming diagnosis, clinician should consider the severity of exacerbation to guide the management. Severity of asthma exacerbation is defined as change in vital sign. Severity of COPD exacerbation was defined historically by treatment used in the severe disease requiring emergency department, visitor hospitalization, or global initiative for COPD report now recommended using objective data first outlined in 2021 Rome proposal then more closely mirror severity grading of asthma exacerbation. Major differences between definition of severe disease are focused on peak expiratory flow and FEV1 in asthma. So severe disease being defined as peak expiratory flow or FEV1 of 40% to 50% of predicted and best measurement and life-threatening asthma as less than 25%. The incorporation of elevated C-reactive protein and acute hypercapnia in COPD exacerbation. Then pathophysiological event. Asthma often is mediated by activated T helper 2 cell, mast cell, and eosinophil, where COPD exhibit predominantly type 1 cytotoxic cell, macrophages, and neutrophils. However, substantial overlap exists between these two inflammatory states. COPD can be eosinophilic predominant, and severe asthma exacerbation commonly demonstrate mixed eosinophilic and neutrophil inflammation. During exacerbation, the inflammatory response typically progresses over several days, causing vascular permeability and airway swelling. In addition, airway resistance increases because of bronchospasm, and a more prominent feature of asthma exacerbation, and mucus plugging within this air small air. Increased airway resistance may be compounded by expiratory flow limitation, whereby airway closes prematurely because of reduced elastic recoil. The resultant airflow obstruction in asthma and COPD exacerbation causes ventilation perfusion mismatch, increases expiratory time constant or the time required to exhale, 63% of tidal volume, calculated as lung resistance complaints. The longer time constant may prevent return of alveolar pressure to atmospheric pressure and cause progressive gas trapping and dynamic hyperinflation in the setting of tachycardia. So dynamic hyperinflation reduces the compliance of the lung, which is now operating near top of the pressure volume curve, and mechanical efficiency of diaphragm, which is now flat, leading to unfavorable length tension relationship and increased respiratory muscle work. Eventually, this mechanical disadvantage can lead to fatigue and respiratory failure. Thus, the primary goal of the treatment are to reduce airway inflammation, to reverse bronchospasm, and in severe cases, to offload respiratory muscle with mechanical ventilation to support patient while waiting improvement in the airway inflammation. Now about inhaled bronchodilator. The cornerstone in the management of asthma and COPD exacerbation is inhaled bronchodilator to treat bronchial hyperactivity and to reduce uh, airflow obstruction. So first line therapy is short-acting beta agonist. SABA can be delivered equally effectively using meter dose inhaler with spacer device, with dry powder inhaler or via nebulizer. However, nebulized administration may be preferred for patients who are critically ill and who are in respiratory distress and can unable to cooperate with the inhaler or dose or both. Adult patients who are critically ill with the severe exacerbation should be treated with the short-acting muscarinic antagonist in addition to the SABA. In severe asthma exacerbation management in ED, combination of SABA and SAMA resulted in greater improvement in peak expiratory flow to FEV1 ratio and fewer hospitalization compared to SABA treatment alone. No quality studies have evaluated the role of SAMA in the COPD exacerbation or among patients in ICU. However, they are recommended for severe exacerbation. Now, the pharmacotherapy for the severe asthma and COPD exacerbation managed in the ICU. So first is the SABA. The mechanism of action is bronchodilation and smooth muscle relaxation by stimulating airway beta 2 receptor. So the regimen is we can deliver it by the MDI or DPI with spacer and nebulizer. So the if we are planning to deliver it by spacer, then the dose is albuterol 4 to 8 inhalation every 20 minutes for 3 doses, then 2 to 4 inhalation every 1 to 4 hours. Nebulizer albuterol 2.5 to 5 mg every 20 minutes for 3 doses, then 2.5 to 5 mg every 1 to 4 hours. For COPD, the dose is if we are using spacer, albuterol 4 inhalation every hour for 3 doses, then 2 to 4 inhalation every 2 to 4 hours. And in case of nebulizer, the dose is same, that is 2.5 mg every hour for 3 doses, then 2.5 mg every 2.2 to 4 hours. The comment is albuterol and the levoalbuterol have similar outcome and safety profile. Albuterol is recommended as the first line agent MDI and the DPI with spacer and nebulizer provide similar benefit. Nebulizer may be preferred in patients who are critically ill and unable to cooperate with the inhaler. For COPD, nebulizer should be driven by air rather than by oxygen to avoiding worsening hypercapnia by overoxygenation. Transient nebulizer to inhaler as soon as patient is stabilized to promote teaching and the earlier hospital discharge. Then the next is short-acting muscarinic antagonist. The mechanism of action is bronchodilation and the smooth muscle relaxation by inhibiting muscarinic acetylcholine receptor. So we can also deliver it by the MDI spacer and nebulization dose. In case of asthma, the dose is 17 microgram, 4 to 8 inhalation every 20 minutes for 3 doses and then every 1 to 4 hours. Nebulizer, if you are planning to give nebulizer, then the dose is 0.5 mg every 20 minutes for 3 doses and then every 1 to 4 hours. If in case of COPD also the dose is same and MDI with spacer and nebulizer provides similar benefit. Nebulizer may be preferred in patient with the critically ill patient. For COPD, nebulizer may be driven by air rather than oxygenation. Transition to nebulizer to inhaler as soon as patient is stabilized to promote teaching and early hospital discharge. Then the next modality of the treatment is corticosteroid. Systemic corticosteroids are important therapy for severe asthma and COPD exacerbation as their use is recommended for patients who do not respond to initial bronchodilator therapy. Interestingly, although corticosteroids are recommended for both the disease, their benefit in the COPD exacerbation seem to be driven by a subpopulation with high T2 inflammation and elevated eosinophil count, drawing interest in the using eosinophil level to guide steroid administration among patients who are not critically ill. Strong evidence supports corticosteroid for asthma and COPD exacerbation treated in the acute care setting. Few studies have evaluated corticosteroid in adult patients who are critically ill with asthma exacerbation, particularly those necessitating mechanical ventilation. For COPD exacerbation requiring mechanical ventilation, one study found that corticosteroids were associated with reduction in duration of invasive mechanical ventilation and rate of NIV failure, whereas an other study found no difference in outcome. Among patients managed in the acute care setting, the recommended regimen is prednisolone 1 mg per kg per day up to 50 mg per day and equivalent for 5 to 7 days for asthma and prednisolone 40 mg per day for 5 days for COPD. Based on studies showing shorter course resulted in similar rate of treatment failure and relapse with reduced risk of pneumonia and death. Of the few studies conducted in the patient who are critically ill, most use higher doses. However, very high dose, for example, methylprednisolone of more than 240 mg per day, have been associated with increased treatment failure, duration of invasive mechanical ventilation, ICU or hospital length of stay, adverse event including hyperglycemia, requiring insulin therapy and fungal infection. Currently, evidence to suggest routine use of higher corticosteroid doses is limited. We recommended prednisolone 40 to 50 mg per day for at least 5 days with consideration of higher doses in patients with life-threatening disease or those not responding to initial therapy. So corticosteroid, it inhibits the transcription of inflammatory mediator, prevents the recruitment of eosinophil to airway and induces the eosinophil apoptosis. So for asthma, the dose is prednisolone 1 mg per kg, maximum 50 mg for 5 to 7 days. For COPD, the dose is 40 mg per day or equivalent for 5 days. So regarding corticosteroid, higher doses can be considered on case-by-case basis and very high dose, that is methylprednisolone more than 240 mg per day, should be avoided because of worse outcome. Corticosteroid with primarily glucocorticoid effect generally preferred over those with the mineralocorticoid effect as more extensively studied. Per-oral and IV formulation have shown similar bioavailability. Per-oral recommended for most patients because of quicker onset and lower cost. About antibiotic, studies investigating the role of antibiotic therapy in asthma exacerbation, and none of which included patients in ICU, found no difference in symptom and the lung function with addition of antimicrobial. Among a more recent large retrospective study of early antibiotic treatment among patients hospitalized for asthma exacerbation showed reduction in composite measurement of treatment failure defined as initiation of invasive mechanical ventilation, transfer to ICU, hospital mortality, and readmission. Treating clinicians should administer antibiotic to patients with asthma exacerbation who are critically ill if concerned about concurrent lung infection. However, data to support a standard regimen of antibiotic in this population are limited, consistent with the Global Initiative for Asthma recommendation for hospitalized patients. Antimicrobial therapy should be given to patients with COPD exacerbation who are critically ill and who exhibit increased dyspnea, sputum volume, or purulence, or those requiring mechanical ventilation. Antibiotic decreases the risk of treatment failure and mortality in patients hospitalized with COPD exacerbation, driven by a subset of patients who exhibit increased sputum purulence or may be surrogate for bacterial load. Macrolide and tetracycline are mainstay of option, although anti-pseudomonal agent should be considered for patients with risk factor for pseudomonas. Antibiotics should be continued for 5 to 7 days, as long course have not been shown to change the clinical outcome. Currently, evidence is sufficient to implement routine use of biomarker to determine antibiotic administration. So the antibiotics mechanism of action is bacteria eradication by inhibiting synthesis of nucleic acid, protein, and cell wall. Aminopenicillin with clownic acid, macrolide, tetracycline, or equivalent coverage for community-acquired pneumonia for 5 to 7 days. Increased dyspnea, sputum volume, and sputum purulence need three or two if sputum purulence is present, or patient requiring NIV or invasive mechanical ventilation. Aminopenicillin and clownic acid and macrolide or tetracycline for 5 to 7 days. Consider anti-pseudomonal agent if risk factor for pseudomonas, chronic colonization, FEV1 less than 50%, bronchiectasis, and chronic steroid use. Then about other medication, IV magnesium sulfate has been shown to reduce hospitalization among patients with life-threatening asthma exacerbation and COPD exacerbation in ED. Therefore, should be considered in patients not responding to initial therapy. The use of ketamine and dissociative analgesic with bronchodilator effect have been suggested in patients who are not intubated at low sub-dissociative doses. However, quality data showing clinical benefit are lacking. Some interest exists in using biological agent in asthma exacerbation, given the irrelevant quick onset over days. Although data have been limited to the case report and randomized control trial demonstrating that benralizumab administered in the ED reduces the rate of recurrence exacerbation in subsequent 12 weeks. Methylxanthine and terbutaline and beta 2 IV beta 2 agonists are not recommended for asthma COPD exacerbation among adults because of their lack of efficacy compared to the inhaled beta 2 agonist. Methylxanthines are associated with increased side effects and adverse effects like tachycardia. About inhaled gas, the one of the volatile anesthetics for life-threatening asthma exacerbation have been described in some in case reports. Although prospective data are insufficient to support their use, outside the refractory case of bronchospasm until their further research is carried out. No role exists for volatile anesthetics in severe COPD exacerbation because studies showed mixed effect on respiratory mechanics compared with the IV sedation. Helium oxygen mixture used to promote laminar flow and to reduce the airway resistance may improve the respiratory mechanics during the severe asthma exacerbation, although data are limited on meaningful clinical outcome. Among COPD exacerbation requiring NIV and or invasive mechanical ventilation, Heliox improves the work of breathing and intrinsic peak. 2 RCT for COPD exacerbation requiring NIV found that Heliox did not improve NIV failure. However, a trend towards lower intubation rate and greater times to NIV failure were noted in Heliox group. Heliox could be considered on case-by-case basis as an adjunct therapy for patients with severe asthma and COPD exacerbation refractory to other treatments. About supplemental oxygen. Many patients managed in ICU with life-threatening exacerbation will demonstrate hypoxemia resulting from the VQ mismatch. Hypoxemia typically is mild in asthma and even during life-threatening exacerbation. PO2 of 30 to 50% should prompt evaluation for another cause. Supplemental oxygen should be initiated and titrated to target saturation of 93% and 95% in asthma and 88 to 92% in COPD. Administration of excessive oxygen can promote hypercapnia because of worsening VQ mismatch and offloading of CO2 from hemoglobin as a result of Heldon effect, in which CO2 bound to hemoglobin is removed when oxygen becomes deoxygenated. More importantly, hyperoxia is associated with increased mortality in COPD exacerbation. High flow nasal therapy. High flow nasal therapy delivers heated and humidified oxygen through nasal cannula at flow rate of 60 liters per minute. High flow nasal therapy more accurately delivers the high FR2 compared with the conventional oxygen therapy. It improves the CO2 elimination by washing out CO2 from upper airway where gas exchange does not occur, generates the low level of PEEP, generates the low level of positive pressure that may recruit the atelectic lung and improve both VQ mismatch and lung complaints. One small RCT comparing high flow nasal therapy with the conventional O2 in severe asthma exacerbation complicated by respiratory failure showed that high flow nasal therapy improves oxygenation, heart rate, respiratory rate without differential change in PaCO2. Otherwise, data on the high flow nasal therapy for severe asthma exacerbation are very limited. Among patients with COPD exacerbation or stable COPD, high flow nasal oxygenation improves patient comfort, work of breathing, and alveolar ventilation. The few studies evaluating high flow nasal therapy versus conventional O2 therapy for COPD exacerbation found that high flow nasal therapy did not reduce the need of NIV or invasive mechanical ventilation or mortality. Several small studies comparing high flow nasal therapy with NIV in the treatment of COPD exacerbation with moderate hypercapnia found similar reduction in COPD treatment rate and mortality. However, almost one-third of patients receiving high flow nasal therapy require NIV within 6 hours in one study. More recently, larger non-inferiority RCT in same population showed that high flow nasal cannula was associated with higher rate of treatment failure and intubation, but no difference in ICU and hospital length of stay or mortality compared to NIV. NIV should be considered before high flow nasal therapy for COPD exacerbation with respiratory acidosis. However, high flow nasal therapy can be an alternative in patients who do not tolerate NIV and would benefit from alternating between these methods or both. Non-invasive mechanical ventilation. Non-invasive ventilation counteracts several aspects of dysfunctional pathophysiologic characteristics exhibited during exacerbation. NIV recruits the alveoli through application of external P. In addition, external P offloads the inspiratory muscle by reducing negative inspiratory force needed to overcome intrinsic P or the positive alveolar pressure at end expiration, resulting from dynamic hyperinflammation and triggers an assisted breath. The pressure support delivers in addition to PEEP also promote greater tidal volume, which ultimately increases alveolar ventilation. The result is an improvement in hypercapnia, hypoxemia, and work of breathing. The role of NIV in asthma exacerbation remain poorly defined. Global Initiative for Asthma guideline do not provide a recommendation on its use. A limited number of small RCT showed that NIV improves lung function parameter and ICU and hospital length of stay. Retrospective studies found that NIV was associated with reduced mortality and the need for invasive mechanical ventilation. Despite the paucity of RCTs, the use of NIV for asthma has increased over last few decades, accompanied shift away from invasive mechanical ventilation without resultant change in mortality and length of stay. We believe the trial of NIV can be attempted for more severe asthma exacerbation managed in ICU with caution in those patients with life-threatening exacerbation. NIV is preferred initial method of mechanical ventilation for acute respiratory failure during COPD exacerbation. NIV improves hypoxemia, hypercapnia, and work of breathing. It reduces the need of intubation, mortality, and ICU and hospital length of stay, while also being associated with lower rate of nosocomial pneumonia. Initial setting depend upon the patient characteristic. However, basic principle include titrating peak to improve work of breathing while not worsening hyperinflation and setting pressure support to target tidal volume of approximately 6 to 8 ml per kg of ideal body weight. Patients should be monitored regularly and particularly early in the course using physical examination and blood gas assessment to guide setting. For patients with persistent hypercapnia, despite initial application of NIV, pressure support can be up-titrated to increase the tidal volume and minute ventilation. Sedative and analgesic medication are used commonly to manage anxiety and discomfort associated with NIV. And dexmedetomidine and adrenergic agonist is an effective sedative agent in this setting, given its lack of respiratory depression and potential to reduce the risk of intubation and length of ICU stay. Although benefit of NIV in COPD exacerbation are evident, it is important to note that in 20 to 30% of patients, NIV will fail and they will require the invasive mechanical ventilation. Risk factor for NIV failure include older age, higher BMI, higher acute physiology and chronic health evaluation 2 score, persistent hypoxemia, and hypercapnia despite 1 hour of NIV. Particular attention should be paid to these high-risk patients to identify signs of early treatment failure. In addition, the HACOR score, the risk score that incorporates the heart rate, acidosis, consciousness, oxygenation, respiratory rate, can be used to predict NIV failure among patients experiencing COPD exacerbation. Diaphragmatic dysfunction defined as change in the diaphragm thickness of less than 20% on ultrasound uh, during VT and may predict during the tidal volume and may predict the NIV failure. But its usefulness in this setting remains an area of ongoing research. Invasive mechanical ventilation. Despite maximum NIV therapy, 1 to 2% of patients hospitalized with asthma and COPD exacerbation will require invasive mechanical ventilation. A decision to pursue invasive mechanical ventilation should be discussed with patient or healthcare proxy if patient lacks decision-making capacity. Importantly, healthcare providers often underestimate the chance of survival for patients with COPD exacerbation requiring invasive mechanical ventilation. Despite this patient having favorable outcome compared with other causes of respiratory failure. Pre-oxygenation should undertaken before intubation if time allows. Positive pressure delivered through invasive mechanical ventilation may worsen existing high intrathoracic pressure because of dynamic hyperinflation, which can result in decreased venous return and periprocedural hypotension. Therefore, hemodynamics should be optimized before intubation with fluid resuscitation and vasopressor such as norepinephrine. Patients with severe obstructive lung disease, particularly those with pre-procedural hypoxia, should be considered as physiologically difficult airway due to risk of periprocedural hypoxia and cardiovascular collapse from the high intrathoracic pressure, impairing venous return to the right. Commonly, rapid sequence intubation is used with the sedative and paralytic agent given simultaneously. Another alternative is delayed sequence intubation, in which induction agent is separated from paralytic to allow additional time for pre-oxygenation. Ketamine and propofol are preferred agents for induction and continuous sedation during mechanical ventilation because of their bronchodilator effect, the former causing less hypotension. Intubation should be completed with the largest diameter endotracheal tube appropriate for size of the patient to reduce the airway resistance and peak pressure and to facilitate suctioning and bronchoscopy if needed and possibly to improve mortality. Initial phase of invasive mechanical ventilation should focus on limiting hyperinflation rather than attempting to normalize blood gases and permissive hypercapnia is encouraged. Control method should be used with no clear superiority of volume versus pressure method. Ventilatory setting aimed at minimizing hyperinflation will use lower minute ventilation and extended expiratory time with lower inspiratory to expiratory ratio to allow time for expiration. So initial setting will approximate the following. Tidal volume of 6 to 8 ml per kg of ideal body weight. Respiratory rate 10 to 12 breath per minute. Peeps from the 0 to 10. Inspiratory to expiratory ratio between 1 is to 2 and 1 is to 4. Inspiratory flow rate of 60 to 100 liter per minute. Trigger sensitivity of -1 to -2 with pressure triggering and 2 liter per minute with fluid triggering. Optimal PEEP will vary based on patient characteristic. However, we suggest starting at 5 or 50 to 80% of PEEP if it is known and titrating based on patient response as discussed. So the patient with the severe airflow obstruction, they are at increased risk of ventilator associated complication resulting from barotrauma and dynamic hyperinflation. So assessment of hyperinflation should be completed regularly by measuring P-plat and P. P-plat is measured in volume control mode via inspiratory flow manual in which set VT is delivered and then airflow is stopped, allowing measured pressure in the ventilator circuit to equilibrate alveolar pressure. Peak inspiratory pressure is the highest pressure measured during inspiratory cycle and it is a function of resistance and compliance. P-plat is the pressure when the flow has stopped and measure the static compliance, which is surrogate for the degree of hyperinflation. P-plat should be less than 30 to avoid barotrauma. In addition, elevated P-plat should prompt an evaluation for other pathological features with lung parenchyma and pleural space such as pulmonary edema, pneumonia, pneumothorax, and pleural effusion. It is important to note that inspiratory hold measure static compliance and not dynamic compliance or lung compliance during normal respiration. That is function of both lung and chest wall compliance and airflow resistance. Dynamic compliance typically will be lower than the measured static compliance in this patient, and it can be increasingly lower in setting of worsening tachypnea because airflow obstruction prevents the emptying of the air from unit with longer time constant within the heterogeneous lung. Another measure of hyperinflammation is intrinsic peak. Slow time waveform expiratory limb that does not return to baseline between breath is indicative of intrinsic peak and should be prompt and expiratory occlusion measure to measure the total peak. So during the maneuver, ventilator allow the exhalation and then temporarily prevent the additional breath from being delivered, causing the pressure in the ventilatory circuit to equilibrate alveolar pressure. The equilibrate pressure is the total peak within the lung, which can be used to calculate intrinsic peak by taking the difference between total peak and set. Elevated PEEP, if therefore, if present, should be minimized by decreasing RRVT and inspiratory to expiratory ratio. Among these, decreasing the RR has greatest impact, although its effects are diminished at low respiratory rate because expiratory flow rapidly decreases after first few seconds. The inspiratory time can be shortened by increasing inspiratory flow rate, changing from decelerating inspiratory flow pattern, so-called square waveform, within flow volume targeted ventilator mode and both. In addition, external PEEP should be titrated to minimize intrinsic PEEP while monitoring for changes in total PEEP and PEEPlet as measurement of hyperinflation. Three different responses to the increasing external PEEP have been described. No change in total PEEP or PEEPlet with with PEEP up to 80% of intrinsic PEEP in patient with expiratory flow limitation. Increased total PEEP or PEEPlet in those without an expiratory flow limitation. Paradoxical decrease in total PEEP or PEEPlet, possibly resulting from combination of expiratory flow limitation and heterogeneous lung. PEEP titration should be stopped if PEEPlet increase. Measurement of PEEPlet or intrinsic PEEP can be elevated artificially in patients with spontaneous respiratory effort. In this setting, deep sedation with or without bolus dose of neuromuscular blocking agent can be considered if accurate measurements are needed to guide measurements. Patients with severe asthma and COPD exacerbation frequently exhibit ventilator dysynchrony resulting from dynamic hyperinflation and high inspiratory flow demand. And dysynchrony has been associated with increased work of breathing, worse hyperinflation, and poor clinical outcome. One of the most common forms is the trigger dysynchrony, in which patient's inspiratory effort is unable to overcome both ventilator trigger threshold or intrinsic peak to trigger ventilator assisted breathing. Trigger dysynchrony can be managed by increasing PEEP to match intrinsic PEEP better or decreasing the trigger threshold. Routine administration of neuromuscular blocking agent is not recommended because of the risk of myopathy, particularly with concurrent corticosteroid use. However, these agents can be considered on case-to-case basis to reduce the patient ventilator dysynchrony, risk of barotrauma, and oxygen consumption among patients who exhibit persistent dysynchrony despite ventilator optimization and adequate sedation. Now about advanced therapy. Patient with life-threatening exacerbation exhibiting persistent severe hypoxemia, hypercapnia, and hemodynamic compromise resulting from hyperinflation despite invasive mechanical ventilation optimization should be considered for VV, especially life-threatening asthma exacerbation because of the reversible nature of the disease and high survival rate among those who receive VV. Importantly, our understanding of VV ECMO in severe obstructive lung disease comes from registry data and in case series rather than RCT. Guideline directed criteria for VV ECMO initiation in severe obstructive lung disease do not exist and decision should be made in consultation with ECMO specialist. Relative contraindication include increasing age, multi-organ failure, and invasive mechanical ventilation with high setting for 7 days. Bleeding diathesis and contraindication for anticoagulation and comorbidities such as terminal malignancy. After cannulation, the VV ECMO flow rates and the fraction of delivered oxygen should be titrated to obtain oxygen saturation. Swift gas flow should be adjusted to normalize PaCO2 slowly because rapid reduction of the PaCO2 is associated with neurological complications such as intracranial hemorrhage, ischemic stroke, and brain death. In addition, ventilatory setting should be reduced to ultra-lung protective ventilation to allow lung rest. Often pressure control ventilation is used targeting P flat of 25, PEEP of 5 to 10 centimeter of water, and RR of 4 to 15 breath per minute. Although these settings are based on the studies of acute respiratory distress syndrome, and setting may be different in patients with severe obstructive lung disease. Additional disease-specific therapy such as bronchodilator and corticosteroid should be continued while the patient is receiving VBA. Now, the extracorporeal CO2 removal is novel strategy that provides CO2 removal without significant oxygenation using small cannulas and lower flow rate. Among patients with COPD and hypercapnia, extracorporeal CO2 removal has been studied as salvageable therapy like ECMO or as a method either to prevent intubation and to promote earlier extubation. However, its role remains limited because of insufficient prospective data and high risk of bleeding and lack of impact on mortality. About extubation, readiness of extubation should be assessed in similar manner to other respiratory disease, requiring improvement in underlying obstructive process, necessitating intubation and ability to follow command during spontaneous awakening trial. Respiratory stability during spontaneous breathing trial with minimum pressure support setting. It remains unknown if patient with severe asthma exacerbation should be extubated to NIV or high flow nasal therapy. Conversely, patients with COPD exacerbation should be extubated to either NIV with same setting used with invasive mechanical ventilation or high flow nasal therapy because both methods have been shown to decrease the mortality, reintubation rate, or duration of invasive mechanical ventilation. Comparison of the NIV and high flow nasal therapy in COPD exacerbation has shown similar effectiveness, although NIV may be more beneficial in patients who are at high risk. Alternating between NIV and high flow nasal therapy also was more effective than high flow nasal therapy alone, method that may be useful in patients who have difficulty tolerating NIV. Importantly, NIV and high flow nasal therapy should be used immediately after extubation rather than waiting for recurrent respiratory failure to develop because the latter has been associated with increased mortality, possibly because of delayed reintubation. Thank you, guys.